my disclosure. Now, I've done a lot of work in the past with the endoscopic GERD treatment, and I think we need to learn from the past before we do, again, some mistakes that unfortunately has killed, this very promising field in the early 2000s. There was some problem with the GERD treatment by endoluminal therapy. Essentially, there was not too much space where endoscopy was going to be deployed. As you can see, medical treatment is very effective, also very low invasiveness. Surgery, maybe more effective than PPIs, but then more invasive. Definitely there was no space for endoscopic treatment. And all this year we were trying really to find a space, but that space was not found, and a lot of companies are now gone. For obesity, it's a little different. Definitely there is space because we have essentially a very ineffective medical treatment. We have a very effective treatment like surgery, but it also is very invasive. Same time in endoscopy we can achieve significantly better efficacy in terms of weight loss, but then less invasive compared with surgery. Then we have an opportunity here with this new field, but we have to be sure we don't repeat the same mistakes we did with the GERD treatment. Why we do endoluminal or endoscopic bariatrics? We know that right now with the Center of Excellence, growing experience, definitely we know there is a less complication rate. But still, we have some significant complication. There is still death in our case series. Therefore, there's always a strong interest to reduce that risk with endoluminal device techniques for standalone weight loss procedure. I think in the past we did very, very well. In the last few years, we tried first to do endoluminal revisional surgery. We have developed a lot of tools, a technique that can be used finally to make a very good standalone weight loss procedure. Now, when you do bariatric endoscopic surgery, you can achieve essentially an ambulatory weight loss procedure that definitely can be safer than a more invasive procedure like surgery, also more cost-effective. We have to face a new challenge now with the new health care costs. They're rising, and definitely maybe can be more cost-effective than surgery if we can prove that it's a safe and maybe equally effective of surgery. Now, if you look at the current status of Endo-Bariatrics, we have seen a lot of this presentation today. We can use intragastric balloons. Unfortunately, in the US, they're not approved by FDA. We hope to see them soon. Also, we have endoluminal suturing and stapling device. And we're trying to reproduce the same array of tools we use in laparoscopic surgery. I think that is the right way to go. Now, if I look at all these procedures, Dr. Fogel showed this morning, essentially, they're all trying to reproduce a gastric restricted procedure like the VBG, or maybe an endoluminal sleeve. Definitely, to date, it's very hard to see that someone is trying to reproduce what is the gold standard right now in the US of the weight loss procedure, the gastric bypass surgery. There's also other device like the duodenal sleeve that is interesting, but definitely, I can see them used in the short term. They're not really, probably for long-term use. Now, the endogastric why, essentially is the holy grail, I think, of any bariatric surgeon. Do the gastric bypass, very effective, for now very safe too, but doing with endoscopic means. And I think that we should really try. I think is maybe still a myth, but I think we're getting close now to, maybe in the near future to do so. We have to try essentially to develop all these techniques that we use in laparoscopic surgery to try to perform this endoscopic, big procedure. Essentially, the gastric bypass is a procedure that has several components. And I'm going to show you which components. And I can tell you essentially at this point what was achievable, what wasn't achievable. Really, when they give me these talks, I was thinking, definitely, to date, there is no evidence that anybody has done in animal, on humans, an endoscopic gastric bypass. But I think the real challenge is really to predict the future, maybe the near future. These are the 5 components we achieve when we perform a gastric bypass. First, the gastric restriction. Then we have to provide exclusion of the stomach remnant from the alimentary flow. Essentially, we complete the exclusion of the gastric pouch. Also, we have to provide exclusion of the proximal intestine from alimentary flow. We have also to provide exposure of jejunum to partially digested nutrients. Also, delivery of partially digested nutrients to the distal intestines. The two last comments are very important for the effect of metabolic surgery of gastric bypass surgery. We have to achieve that also with endoscopic procedure. Now, today, really, these are three components that we can really easily achieve at this point. Looking at some of their presentation, they're before me. Gastric restrictions, exposure to jejunum to partially digest, also partially digested nutrients to the distal gut. Gastric restriction, there are several ways to achieve. Dr. Fogel has presented this endoluminal vertical gastroplasty with the Barrett endocench. Definitely, we can reproduce something that, very similar to was a VBG, or maybe an endosleeve. But at the same time, we have some maybe issue with durability. But one beauty about endoscopic treatment, you can repeat them over time. Another one has been already presented is the TOGAM, but can we go back to the previous? Okay. See if you can start the movie, please, the little clip. It's okay. I mean, there's been already shown before, the target then is not necessary to the show. The third one, essentially, is the pose. This essentially is a modification of a procedure already in place, using humans. It's called the restorative, obesity surgery endoluminal. This is a new procedure, pioneered by US GI, that is essentially to create, again, a gastric plication using their device. Okay, video is not working too. Okay, if you look at in terms of what is up to date for the gastric restriction, it's feasible, but definitely there's some concern. In my opinion, I've done a lot of endoluminal also work with the endoscopic suturing. Durability is probably the first concern. In other devices, especially the Barrett endocench, when there was the use in the GERD treatment, if you rescope this patient, 12 months after the endoscopic treatment, few implants are still in place. Then we have essentially to improve, the device to provide more durability. But again, if that happens, maybe durability can be also improved by just repeating the procedure. Also, one problem I have, with a few exceptions, essentially that most of these procedures, we never achieve the amount of weight loss we achieve with traditional bariatric surgery. And that's, for me, is a concern, because definitely we want to have a significant difference with what you can achieve with the medical treatment. Now, if you look to the bypass component, this also can be achieved by endoscopic means. With bypass component, what you want to do is essentially expose the jejunum to partially digested food. They also expose the distal gut to undigested nutrients. You can use the Endo-Bariatrics system that has been already presented, that is to deploy this device into the jejunum, providing essentially a malabsorption. But this device, one problem is that you cannot keep in place for many, many months. After a while, you have to remove it. Definitely, we know that obesity is a long-term problem that requires a long-term solution. I think a more interesting way to provide a distal bypass is to do a Gastro-Jejunostomy. Can you please run this clip maybe alone without PowerPoint? This was done by Dr. Bergstrom in a pig model. That's more really a nodes procedure than really a true endoluminal procedure. You enter, the peritoneum in the traditional way with the nodes approach. You grab essentially a small bowel loop with a grasper. Then using a loop, you can deliver a loop of bowel into your gastric opening. At this point, there has been several variations. In this case, they're going to use some T-tags, endoscopic T-tags, to secure the loop to the opening. But several other devices can be used. I think as you can see, it's pretty easy, fast. And once you have secure, you can use the cautery to open up the anastomosis. This system, that's been developed by Ethical Endosurgery, doesn't require, really removal of the endoscope. You can load all these, T-tags, keeping the endoscope in place. And that is also very important because you want to minimize the time you introduce the scope back into the esophagus. Some people use over 2, but I think the best is really to have instruments that allow multiple placement of suture or device. And now the clip is to hold in place the suture. The next step is really to open up with the electrocautery. And this procedure has been done in a series of over 10 pigs with survivals, essentially with minimal mortality. And also we have a little clip to show the results of this procedure 2 weeks after has been performed. I think Gastro-Jejunostomy really can be achieved at this point, also in humans too. It's very feasible. And I think this is one of the big part of the gastric bypass. I think we're already there in that point. You can see this is the anastomosis just 2 weeks after the procedure. Nice open with a good, on the lumen. But as you can see, this essentially is a loop, gastro-jejunostomy. Definitely is different what we do with the Roux-en-Y gastric bypass, where we do essentially a Roux-en-Y reconstruction. This is more similar to what we can achieve with a mini gastric bypass type of procedure. Now, definitely, with the endo-barrier, we have a problem with durability because we have to remove, the device after a few months. Also, in terms of weight loss, we're not there yet. With endo-barrier, definitely reported weight loss has been less than what has been published with other, maybe less invasive traditional bariatric surgery, like maybe gastric banding. With the loop gastro-jejunostomy, essentially you have a problem with the marginal ulcer. That has been a common problem reported with the, the mini gastric bypass. Therefore, we have essentially 2 components. Still, at this point, it's very hard, really to achieve with endoscopic means. Essentially, how we exclude the stomach remnant from the alimentary flow. Really, we have to create essentially gastric restriction with no, outlet, essentially, complete, and then create a gastro-jejunostomy. Today, it is very hard to do that with the current stapling or current suturing system. Also, the best really is to try to do a Roux-en-Y reconstruction, not really do a mini gastric bypass. Then we have to find a way to exclude the proximal intestine from alimentary flow. I mean, the solution definitely is in my opinion, is has to rely more on endoscopic stapling, because I think that suturing is really time-consuming. Also, I don't think it can assure the same type of reliability that we have right now with our gastric stapling. Nobody really is doing a gastric bypass right now using just suturing. Most of us rely heavily on a stapling device. Then really I have to make a prediction at this point, really not here yet, but definitely maybe in the near future if we have a good partnership with the industry. I think for endoscopic, bariatrics, we need really a good partnership with the industry. And also we have to try not to repeat the same mistake we did with the GERD treatment. Thank you very much.